elevator will help you obviously with sampling if you need to, or getting into the right plane. So that's something to know about. And the other thing is stabilizing the scope. This is where Dr. Hassan and I differ slightly. I tend to like to lock sometimes and then do my FNA. I think most of the time you don't lock, but we just have different, unless it's like it's a tight situation. I just, especially with trainees, I have them lock it because I find that allows them to not worry about the scope moving back. And I'd say most of the time I do it too, maybe just because I find it easier. And that's the other thing, like in anything else in life, you eventually do what works best for you. Both him and I, do a pretty reasonable job with the US FNA, but our approaches are different. And actually, you'll see a lot of how we do EUS is slightly different, but we both look at the same organs and we identify the same structures. It's just how you prefer to do it. But for me, I think locking and then using the elevator tends to work well, especially with trainees. So you can lock it, and then you can use your elevator up and down sometimes to help you. So that's, I guess that was my last slide. So that's essentially it. Any questions? Yes, so it helps in the sense that sometimes, because if this is the stomach and this is your probe up against it, sometimes when you let go of your big wheel, it may move away. So by putting it up against it and locking it, it stays in place, and then your needle can come out against the gastric wall. But you also have your thumb on the elevator and big wheel together, where you can do it without locking it too. And that's perhaps how Dr. Hassan does it without locking it. But it's just sometimes to maintain that tip position, the probe position in one place. But as I said, it's not like you must lock or you mustn't lock. It's very variable based on the situation.
If you pull the big wheel towards you and you lock it, you get in a really good position, and your needle is not even through that, that would be a problem in locking. So when you're going to lock after you put the needle into the scope. Otherwise, needle gives you a trouble getting through the scope, because if it's bent like that, that sheet is going to have a trouble getting through that part of the scope. So what he meant by lock is once you have the needle through that,
then you can,
and then you get into the position, then lock it if it's unstable position. And sometimes we do things, I may think I'm not locking, but based on unstable position, I just without even thinking, it's like riding a bicycle or driving. You don't think when you're driving majority of the time, and but you just lock it because it felt like it's unstable. But the one point is don't lock it before you get the sheet through the scope.
It depends on your level of suspicion, right? So if you think that this makes sense for it to be, say, a bile duct or pancreatic duct, then you don't need to. But if you're in doubt, because especially with the pancreatic duct in the body, you have a small vessel that looks just like a pancreatic duct, and it's people can often get fooled because they're pushing so hard on the pancreas that they're compressing the pancreatic duct, and they're watching the vessel below it and assuming that's the case. So it's not that you have to, but if you're about to sample something and you want to make sure that you're not about to go through a vessel, it's good to change it. Yes, too much flow gain, decrease again. To reduce the noise. Basically, it allows you to reduce the noise. So then only the true vessel with the flow will have that Doppler image, and the tissue around it, you'll get rid of the noise, as Dr. Hassan said.
I think when you're in the process of learning EUS, you get hung up on these small things and miss the major things. So the goal today is not, like, we do not need to name every single capillary, give it a name, okay? Or every single blood flow we see, you don't need to give it a name. And it does not need to have a name. What main thing you need to do is, this is aorta, this is celiac, this is SMA, major branches, okay? This is SMB, the stuff like that. We're going to pay attention to the pancreas. I'll talk a little bit about the station, organ-based, and then Mustafa and I both will demonstrate our ways of doing. And we are different. We have learned a different way, and you will see that difference. But goal is, again, to do a complete EUS examination, take a look at the organs, get the job done safely and effectively. But whichever way you get to it, that should be fine. So don't get distracted by small things. That's what I'm saying, okay? Don't keep asking, oh, what is that small vessel at 6 o'clock or 3 o'clock, which is in the corner? I have no clue what that is. So maybe one of the blood vessels, okay?
Is there any other than that?
Yes, the structure artery wall will be thicker, and we'll show you that when we do these cases. Veins tend to be thinner walled, and then the portal vein, for instance, the liver has a white rim around it. So that's something that you pick up, but the wall is another way to look at it. But smaller vessels you can't really tell. It's more so in bigger vessels. You tell the wall.
No, I know. Obviously, the structure differently. If you're doing a static arteries, unfortunate scores, I see the vein will be coming straight. So, depending on which kind of structure you're looking at, that's maybe the one that.
Never had
doing the same thing, and you start getting a sense of this shouldn't be or especially that cut vessel differentiation. A lot of people would start to know this is the PD. Fellows will say, often say, what's the PD? Now say, put the doctor on. The doctor on the vessel. And then all I have to say is, no, get extra picture. Because they're compressing. Think about it. The cold is here. You're really pushing down against it. Because you're compressing. All it does is relax you full. And now you stop compressing it.
So I guess the key theme here is the balance. For doctors, you can go too bright, you can lose time, you have less bright, you won't even see it. Likewise, that pressure thing is, air is the enemy. So you want to have as little air as possible. But therefore, you would want to maintain a contact and have a good coupling with the mucosa. But in doing so, at the same time, you don't want to cause too much of a compression, and as a result, you reduce the caliber of whatever ductal structure you're seeing it, and you can just compromise your EUS views, which is what the aim is, to have an optimized image to be able to interpret the anatomy and pathology.
Assalamu alaikum. So Mustafa was telling me if he wants, he can. If I want, he can introduce me. I was like, no, that's okay. I can introduce myself. Okay. So I think we'll keep focusing on the main thing. Just the goal is going to be for each of you to have the basic concepts. You have certain areas where you have some difficulty, and you'll do first EUS, and the second one we will pay more attention to you guys where we thought you had a difficulty before. majority of the people, as many of you mentioned at D1, I have my way of doing it, or my way of teaching it. Hopefully that would help. So I'll show you that. D2, yeah, as Mustafa mentioned, majority of the people, usually when they start doing it, they have a problem with the D2, and especially the scope movement from D2 backwards. Other thing is, just you have to have this concept, but the concept should not be wrong. Just don't make up the things. But one thing really need to know, important thing need to know is that image, shape, or how it's gonna look like is gonna depend on the position of the transducer of the scope. And that constantly changes. Okay? When you're looking at from the stomach, and at that time, the pancreas, you're looking at the way I have learned it myself is by reading the anatomy books, that atlas, natural atlas, looking at the x-rays, and then sometimes even during a combined US CRCP case, just turn on the x-ray for a few seconds, see what the scope position is. I'll show some scope positioning and how it looks like. Because when you're looking at the pancreas from the stomach, the way I imagine is like, okay, I'm looking at on top of it with the transducer sitting on the body. To take a look at the tail, I need to move my transducer this way. This is how I'm imagining. And then go to tail further. Okay, need to go to the neck. I'm going this way. Okay, so this is like I'm looking from top, bottom down. Okay, that's how I would imagine. So body is here, neck is, tail is here, neck is here. But this is like looking from the top, scope is straight in the stomach. When I go into the duodenal bulb, scope becomes long, right? And transducer goes up like that. So now I'm imagining from the duodenal bulb, I'm looking from bottom up. So the pancreas is gonna flip. So head is gonna go this way, neck is gonna be this way, body and tail. We'll show you all this as we move along. So what my point is, really based on what the position of your scope is, where your scope is, the imaging, positioning, and the shape is going to change. So just keep that in mind. It's like, as Mustafa said, ERCP, very static. It's a dynamic procedure. In one place you are sitting, you're just going to get that image. You're not going to get any other image. So this is constantly moving around, but the movements are small. It's not like colonoscopy movements. It's a very layered, small movements. That's what you're gonna do. And other thing is, whatever you want to examine the area or wherever you want to focus, do your best to bring that between 5 and 7 o'clock position. Okay? But that's not gonna work always. That's not gonna happen always, but do your best to keep that in that between 5 and 7. That's how you're going to get the best image based on the same principle. Like with the ultrasonic goes straight down, straight coming back up, going to give you the best image. If they are on the side, it's going to get scattered. And that's where going to be the artifact. So that's what's the main reason, goal is with that, keeping that at 6 o'clock position basically. And Mustafa already mentioned, showed you the picture. So another concept about the camera is 2 centimeters behind the tip. Okay, so if you are going through the pylorus, it's just like a ERCP scope. I always say that, and you probably heard that many times. Endoscope, camera in the front, looking front, moving forward. ERCP scope, side view, looking at the ceiling, moving forward. EUS, with the ceiling and the wall meets. So it's at 45 angle. On top of that, introducer or end of the scope is 2 centimeters beyond the camera. So if you are at the pylorus and you are looking at the nice pylorus completely, your end of your scope already got into the antrum and buried down there. So you're never going to get through the pylorus. So you have to pull the scope back a few centimeters and then guide it through the pylorus. So that's the concept. D2, if you're looking at the ampulla, I'll show that. If you're looking at the ampulla, you put your big wheel towards you, and that's the other term here I already mentioned about the way I'm going to use it. I think you use the same way too. Big wheel towards you, big wheel away from you. Same thing is with the small wheel towards you, small wheel away from you. So please pay attention to that when we say that, okay? Rotate the scope to the right means torquing the scope to the right. And that's going to happen just like ERCP scope, with your wrist, with your shoulders, with your body movement. And it's these movements. Other thing is, the one who are taller among you, you can stand and hold the scope. There should not be a bend in the scope. Scope should be straight. It should not be like that when it's going through the mouth. So for the one who are shorter, step back from the patient to keep the scope straight. The goal is, whatever you are doing with your hand at this handle of the scope or the wheels of the scope, whatever movement is happening needs to get transmitted all the way to tip. Goal is 1-to-1, as Mustafa showed in the video. If it's not getting transmitted 1-to-1, your scope is very uncomfortable. An uncomfortable scope is not a happy scope. Okay? It's not like the other thing I usually say is, you need to be comfortable. You're gonna get tense. So when we tell you relax, just relax. It's okay. Don't be anxious. Okay? It's scope is you are relaxed. Scope will be relaxed. Scope is relaxed. You are relaxed. Patient will be relaxed too. And most importantly, people sitting here watching you should not be nervous. More nervous than you are. Okay? So just you all are gonna do just fine. Just relax. Scope straight, and just pay attention to if we tell you to do something. Okay. So, how much time we have? I already spoke like 10 minutes, right? Half an hour, okay. And one other thing we'll do, I think we'll demonstrate a case too, like without the training. And we'll demonstrate 1 or 2 cases. One of us just to show like what is expected, how to do the movements. So that way at least you know what we're talking about. Okay? What time is it right now? We'll keep going. And so, history of the US, I always tell about, like, I don't think I need to go through. Main thing is basically started in 80s, and at that time those old machines, our teacher tell us, they were so bulky, and when you talk about that we're going to do EUS, there would be a silence of death in the room because nobody wanted to do that. And then it's like mostly in the beginning, even the users were trying to figure out what it looks like, what we're looking at, what are the wall layers and all that stuff. Basically, main breakthrough was when that linear scope was made. Radial scope, Mustafa already showed you. Radial scope, linear scope, radial CT scan images, okay? And linear, this is sagittal, right? Sagittal images, okay, like that. With the radial, you're doing just an imaging as does the CT scan, okay? So that's good, keeping in mind. For the radial, if you are looking at the pancreas, you're looking at the pancreas like that. To see the upper part and lower part, you have to move the scope in and out. On the other hand, when you're looking at the linear, you're cutting that right through this. So you have to move the scope right and back. That's what happens. So this is the first breakthrough FNA was performed in 1992 by Dr. Wellman in Denmark for a mediastinal mass or lymph node. And that's where it started, the biopsy. But main breakthrough was the interventional EUS, which came around 2005 or so. the diagnostic role, mostly with regard to the cancer staging, we don't use it much. CT scan is much better on the new CT scans, MRI, cross-sectional imaging. That does a lot better job nowadays, but mainly it's for diagnostic, means biopsy, and other is interventions, and then lamps came and all that started. But mostly nowadays, we use it not for the cancer staging, unless it's a luminal cancer where it does help with the T2, T3, but mostly it's used for biopsy and interventions. So you saw some of those images, the old ones, the old machines. I won't go through that. So diagnostic, as mentioned, biopsy of the masses, of the liver, and therapeutic, you already saw that. You saw those scopes. The scope in the middle is the for bronchoscopy, for the endobronchial ultrasound. So that's a much smaller scope as compared to the radial linear scope which you use. Mentioned about that a bit already. With the radial, you can't do a FNA because when the needle comes out of the channel, it looks like a dot because the transducer is not looking at it straight. That's like a CT image. So that's why even though radial has a working channel, you can't do a FNA because you're not going to be seeing the needle through that. For the FNA or FNB, the needle needs to go in front of the transducer, and that's why we use a linear for that purpose. So these are layers. I think I won't go through that. You already know that. And the terms we already, I think Mustafa mentioned about, what is it? But you talked about like how the fluid gonna look like, solid gonna look like. So I think it's important to know, based on the echogenicity, like anechoic means basically there's no echogenicity. When it's too white, like fat, it's hyperechogenic. And somewhere in the middle is gonna be hypoechogenic. And fluid is anechoic as long as the blood is anechoic, as long as it's flowing through the vessel. A clotted blood is going to be hyperechogenic. It's going to look white. It's not going to like, that's other thing with the fluid is, so keep that in mind. Masses, they are between hyper and anechoic, so they are not as black as the fluid looks like. And then hyperechoic or clotted blood, as I mentioned, ear just scattered everything. Really don't see that artifact there. And the fat and stone, looking at it, but then they give a shadow, which is black, obviously. But so these terms, you need to know and use them appropriate. Now, coming to performing US, how many do a station-based approach, like those who have done? So you start from station 1, you start from station 6, how you do it? Okay, you go all the way to the duodenum? Okay. So in the by the textbooks, there's only number 1 to 6 is, 1 is the D3, 2 is D2, duodenal bulb is 3. So we're talking about the textbook stations right now. How many do by that? Yeah, so what I'm trying to get at is, like those station approach, when they were doing the US, our teachers or mentors, they came up with these stations, but you don't have to follow those. So stations are basically the way I think all of us do is basically an organ-based approach. And for me personally, the way I do is I will start at the GE junction. The stomach is station 1, duodenal bulb is station 2, and then beyond duodenal bulb, second or third part of the duodenum. So that's how we do. Another way approach is, if especially in patients which are really not, they can't tolerate the anesthesia much or some instability, but you gotta do a EUS, in those cases, my station would be to answer the question, whatever that is. Do I need to take a look at the bile duct quickly if there's a stone or not, because patient is septic? So then I won't be spending too much time in the stomach. I'll go straight to the bile duct, take a look at that. So that would be my approach to that patient. But if you have time and patient is stable, make this habit, do a complete EUS examination in every single patient. Even though you are doing it for a lump or a bump or a stone, but take a look at the pancreas, take a look at the bile duct, take a look at the GE junction, celiac axis, SMA. Like do basically a complete EUS examination. And also liver, you can basically take a look at the whole liver. Maybe not a whole liver, at least a part of each of segment, all those 8 segments. And also the penetration of EUS, the best is up to 6 centimeter or so. Beyond that, really you get a lot of scattering and you may not be able to see anyway, and liver is so big. So you still, it's a kind of a solid enough organ. You can see majority of it, but sometimes it's out of reach of the ultrasound. So, but most of the time you can see the whole liver. This is the, and other thing is, when you're gonna get, you're doing, and sometimes, especially when you do first few hundred, you're gonna get lost. You go, they're not able to find a station, or not able to, I should say, find your area of interest. Then come, spend a little bit time, see if you can find your way out. Just don't imagine it, just actually find your way out or not. If not, just come back to the area which is more familiar to you, be it a GE junction, be it a duodenal bulb, and start over from that. So no need to spend too much time in one area and just moving the scope right, left, have no idea what looking at it. And so don't waste time over there. And about the Doppler, we already talked about that most of the day. So this is what I want to show you. These are few these cartoons that's going to show you, like this is a scope right here at the GE junction. Right here, right? It's going to come down, it's a linear scope. I want you to take a look at it, how the scope moves and how the position of that transducer changes and how the different organs are being examined by that transducer. You see where that is? You move the scope, it's looking right here, these organs. You change the scope now, how many organs are coming in that view? So this is moving around. So that's like, let's imagine, this is what I was saying. I'm imagining myself looking from top down. Okay, just that's the imagination. Okay, now the scope is here in short scope position, straight. Okay, next one. So now scope coming down, more like in the long scope position, and in the duodenal bulb, and look how the change, like the transducer ultrasound scope is gonna give you the image what's in front of it, right? And that's how it's gonna get transmitted to the screen. So it's not like same direction all the time. That's what I'm trying to say. So every single time that this is gonna change based on where the scope is and how you are moving it. So orientation is going to keep changing based on your scope position. And now it's going to go into the D2 and see, earlier it was looking at it, this from angle, so giving that view, now it goes down and looking it from the bottom up. So every time, again, changes the base. So you will need to imagine, need to memorize how that structures what you are looking at, how they are moving away from your transducer. That's how you're gonna, like really, that concept, when you get that, it will become easier. Because when you're looking at the pancreas from here, You're looking at your tail, as I said earlier, I mentioned, is to the right, neck is to the left, but when you are in the duodenal bulb, because you're looking from the other side now, so everything is going to flip. The image from the duodenal bulb is going to be, your head is there, like you see that stack sign, you see the portal vein, you see the pancreatic duct, bile duct, you move it towards your scope towards the, rotate it to the right to go towards the papilla, right? And then rotate it to the left to go towards the liver hilum. So in that case, your pancreas is now like this. So your head comes here, uncinate is here, neck is here, body is here, tail is here from duodenal bulb. But from the stomach, what was happening, it was completely flipped the other way. So just get that concept. That would, once you get that imaging would make it much better for you. From the way I start is, again, we talked about that. For us, for me, the first station is GE junction. Right below that, celiac artery, SMA. That's my first station. So that's right below the diaphragm, celiac artery. That's kind of a landmark for us.